Hello everyone. So we are here from SGPGI team and with me is Professor Satyen Tiwari sir and Dr. Ankit Sahu, and we have our resident team of Dr. Shahnawaz and Dr. Shubham. So today what we are going to present is a case of acute coronary syndrome in young MI. So can you have a case discussion with the history of the patient? So can we have the history on the slide? Yeah.
The patient is 33-year-old male patient, and he's a young patient with history of acute onset resting chest pain on 16th July, and he is presently have a resting chest pain. All the hemodynamic parameters are normal. The ECG shows NST-MI along with normal LV size, and ejection fraction is 45%. So we took him for angiogram, which was Dr. Rupali. Can you
Yes, sir.
summarize the angiogram?
Yes, sir. So it's a just hemodynamic biochemistry parameters. If we see is a young male, just only his factor is smoking. His cholesterol is normal. It's 79. Despite that, he has developed an event. So we took him for angiogram. Can we have an angio, please? Next. So this was the angio which we did. This left main was normal, and LCX is free of significant. It is a co-dominant LCX having one PLB from left circumflex. And if we see the LAD, LAD is having a proximal severe disease and having some haziness. So can you go next?
Proximal ectatics.
So and in the proximal part we can see the ectatic LAD followed by a critical stenosis and some haziness in this case. And next, if we see the RCA, RCA is co-dominant having both PDA, PLV and free of significant disease. So what we are dealing with, sir, is I think we are in a young MI having proximal haziness with maybe a plaque rupture, erosion, or thrombotic lesion with a critical stenosis. Any
Along with
comments? Yes, sir.
us is Dr. Ankit Sahu. Dr. Ankit,
Yeah.
how do you like to go about this
So
case?
probably we have done a few check angiograms today, so we can have a relook at them.
And do a imaging?
Yeah, probably imaging is required because we want to elucidate the etiology, whether it is a plaque rupture or something else, and also look at that ectatic segment also.
Yes.
So we need an imaging, probably OCT.
So I think you just wire the LED and do
So
the imaging first.
can we have the today angiogram? Can you run the today
Angio,
angiogram?
please.
So we took him after giving him heparin for another 24 hours, and we just took him for today for angio. And for our surprise, if you see the haziness in the proximal part is gone. So most probably it was a thrombus which we were seeing in the proximal part. And go next. And there is ectatic segment in the proximal LAD followed by a critical stenosis. So the plan, I think, as we have discussed, is like we can go ahead with the wire the LAD and just take an imaging first.
Oh, yes.
That what we are dealing with, it was an erosion, what is a rupture. Before pre-dilatation, if we get a good OCT image.
And Dr. Ankit and Dr. Rupali, the problem is that the proximal segment is ectatic.
Yeah.
So we have to take care, we know what exactly it is, because there are high chances of restenosis in ectatic segments.
Yeah. Also, we have to clearly demarcate the landing zone, especially in ectatic
That's
part.
right,
Yeah.
because once you stent the ectatic segment, you have to be sure whether it is a well opposed or not.
It's a test. So the malapposition will be definitely in the ectatic segment. So we have to minimize the malapposition how much we can. But sometimes we cannot able to do it fully. So let's see what we are. Did I
I think
shape
we
the
have to
wire?
shape the wire.
Yeah. It is an acute angle from the mid segment of LAD. So you have to just make it little more angulated. See the outcome, there is a paper on the outcome of the long-standing outcomes in stenting of the ectatic segment, which is disease. So which says that the recurrence rate and the incidence of restenosis is pretty high. So we like to do a imaging first and then see
Test.
how it responds.
So that is only issue. Giving a more bent is like critical stenosis. You have to be careful.
Apical.
This is going in the septal.
Septal. Yeah.
Aram se, slowly.
Can I have a epicaudal view? Yeah, okay, crossed.
Epicranial.
Make it epicranial. Yeah, that's better.
I think diagonal.
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 Just diagonal.
Yeah.
Yeah, this is ready.
I think we should do our imaging first and then do a balloon and then see how response is.
So they found in STEMI the plaque erosion came more common than compared to the rupture, which is very unusual. Like it. Where? Okay.
Okay.
I think we're
crossed.
okay. So
Yeah.
test kar dijiye.
No.
Yeah.
Okay.
Yeah.
So there is some nerd, if you see, there is in the distal part. So sometimes in a very big vessel we face these type of problem. There might
Just
be a
stop it
nerd,
here.
and as expected, yeah.
There is ulcerated plaque at the distal end of the.
So there is a septal which is joining us, and if we see this, just go distally, more distal before the septal, yeah. So this is, if you can see, there is a white thrombus, we can say, which is just protruding inside the lumen, and the intima looks intact. So it's more like a plaque erosion. Just run it. And this is just distal to the septum. This is the septal which is joining, and this is the narrowest part which we got. So if you see the narrowest part, Doko, just stop here. So we can clearly see there are thrombotic lesions, and these all are white thrombus with TCFAs
And
with
there
high
is
necrotic.
ulcerated plaque also,
Plaque
just
itself.
distal to this.
So high necrotic areas with the, but intima looks intact. I don't find intima looks, go up. Yeah, these all are thrombus which is there, and yeah, this is a red thrombus. Can you see this is a red thrombus?
Yes.
So this is mixed morphology, red and white thrombus in this case, and which way we expected also. The young patient with this thrombotic which got recanalized. Can you go up more?
Come little proximal.
And this is the ostia which is, normal. There was a positive remodeled segment, and this is the ostia which is not very significant disease. And if we see the MSA, how much it is coming, MLA?
4.4.
4.47. So MLA is borderline. So go to the LCX. Come to the LCX proximally. Yeah, this is the LCX. So what should be the
LCX,
strategy? Sir? Should we come till the ostia? Or should we come at leave it at the positive remodeled segment, sir?
Show the activity. Stay here. Stay here. So not much thrombus. The good part is. So okay. So probably we have to come to the ostia.
I think we will come till the ostia. There is right.
Yeah.
Huh? What do you say?
Because
Saying something, Ashwini? Yes. Where the disease is, there is a thrombus which is extending up to that part. If you see the ostia is not much. Go to the proximal part. Yeah. So this is not much significant disease. The thrombus just happened just distally to it.
okay.
Yeah.
So
So
take a
I think
balloon.
we will take a small balloon. Can we have a 2.5 mm balloon? Test. Okay, sir. Inflate, sir. This is 15. Okay. Down. So we can take an angle for sizing purpose. Okay.
Just stop it. So we are near to the ostia.
So what's the length in the distal part? Can you tell me what's the distal reference diameter? 3.8. And what's the proximal?
Flush
Lumen.
karna, Vineet.
EL to EL. Okay.
looks better.
We don't want to keep a wire in circumference because
We can keep one wire in the circumflex. There's a wire in the circumflex. So can you just tell me what is the distance between the ostia and the remodeled segment between that part? उसके proximal edge पे it's coming about 10 millimeter, sir. 9 to 10 millimeter.
Hmm.
yeah, so 12 and then this is
Hmm.
to the distal part. No.
Hmm.
Thing looks fine. Test. Thing looks okay. Connect.
Okay.
Looks
Looks
okay.
okay.
Can you stop?
In fact, we
You
are
can look
2
order.
millimeter away from the ostia, 1 meter away from the ostia.
Yeah, I think we were already 12 millimeter, 10 millimeter from the ectatic segment. I think that we are okay. We don't want to commit the proximal part. This should, sir. And you?
Good.
Stop. You
Little
want to 1
more.
mm back now?
Yes, yes, proximal.
Test. I think this is fine, sir.
Hmm.
Looks okay.
Yes.
Okay.
एक मिनट sir, एक minute.
हाँ. Model करना है.
Yeah, let me just confirm this view also. Yeah. रोकिएगा?
मेरे ख्याल से ठीक है.
I think it's okay. क्यों sir?
करूँ?
Yes sir.
Calcium.
2, 4, 6, 8, 10, 12. What is the EL to EL at the remodeling segment? Just tell me, is it 4 or at 4.5? Huh? 4.4. Sit down, sir. This you are telling me about EL to EL, na? Correct. Lumen is 3.5. Test, sir. Okay. अंकित थोड़ा आगे लाना. Okay. So distal edge is well opposed. There is no distal edge dissection. There is some under
Slowly.
expansion in this,
Yes,
looks like.
we expected that.
And coming to the proximal part where the remodeled segment is there.
Remodel segment is
This is the remodeled segment. We expected that there will be malapposition, which is clearly showing. And if we come in the proximal part, let's see what it is. Where we are at the ostia. So this is the LCX and very clear. It is very classically placed at the ostia. So we will take a 4 mm NC.
We have to do.
So we are not at the L6 ostia. It's clear. It's just at the LED ostial which is placed. And can you just?
This is NC4.
It's a 4 mm NC, sir. And can you tell what the remodel segment, what it is, how much it is, and proximal LED? No, go more distally.
Distal under expansion maybe because we hadn't prepared the bed. I mean, we hadn't
Yeah,
pre-dilated.
but
See, we are more concerned about the ectatic segment.
We have to match that.
Test, sir. Yeah, I think that's the
How
part.
much malapposition the ectatic segment? Oh. No.
कितना है उसका lumen
ये
बताओ
lumen-
जहाँ hanging हो रहा है. What is the lumen size?
4.6.
4.6. So we might need a 4.5 mm
4.5,
balloon. So
कितना? Go more.
15.
16. Down.
Distal expansion, ठीक है? Just tell me what is the distal expansion which we are getting. Yeah. How much it is showing?
60% expansion.
इसको भी कर देते हैं.
हाँ, उसको भी इसी से करना है. Yes, high pressure. 14.
Okay. So if we see this OCT, like how it helps us in making the sizing part and not going for very pre-dilatation aggression, because we were already having a thrombotic lesion. So if we have gone more high pressure than NC, we would have caused more distal embolization.
Okay.
यहाँ पे भी कर ही देते हैं सर, फुला दीजिए सर,
Hmm?
फुला दीजिए, मे बी टिल 12-14.
Down.
Down.
तुम जरा इधर आ जाओ मेरे पास, मैं दोनों
ऑस्टिया
को
नहीं
मिल के
आई
आता
अभी,
हूँ इधर
ऑस्टिया
आ
आ जाओ.
Cord, इसको कॉर्डल
कॉर्डल
कर.
सर. लुक्स ओके ना?
देखना.
एक नहीं नहीं, स्टेंट पुश कर रही थी.
क्या आया जल्दी बताओ बस.
चलाना, क्लियर
दिखाओ
स्टेंट करना.
फटाफट दिखाओ. खोलो. कैल्शियम कहाँ है? कैल्शियम है कहीं?
थोड़ा सा लिटिल.
लीजन
पीछे
है.
आना पड़ेगा थोड़ा और.
आगे बढ़ो आगे बढ़ो. आरसीए में भी बंद है क्या? नेक्स्ट. कैल्शियम एलईडी में तो है लेकिन लीजन कोई सिग्निफिकेंट नहीं है. अच्छा ठीक है. इधर कैल्शियम तो नहीं है ना यहाँ पे. ठीक है आगे बढ़ो आगे.
यस सर. 16-18 सर.
यहाँ पे भी तो है लीजन.
18. Down.
Yes sir. 20 seconds. So we will do an OCT. So let's see how it looks like, expansion part and remodel part, and then we can just confirm. No, the remodel part in which no, don't go proximally. Just tell me जहाँ पे malapose हो रहा है from between 20 to 30. Can you see that?
Length 10 mm.
Huh?
6.
That is 6 mm. So we will take a 4.58 balloon. We'll try to do it there and then do an OCT.
Okay.
Is it right, sir? Test.
Oh, clear stent.
Okay. I'm in the remodel part now. Let me just do an angio also.
Unsuitable.
Image unsuitable. Okay. Can you?
Make it little distal also.
Distal, I think we were not 4.5, sir.
Little
Actually,
more.
little
Where
more.
there is a bend. Where there is a bend.
Okay. Yeah.
ACT.
Yeah, it's okay. And just a small puff. Yeah, I think this we're fine. This was the thing. So we will just do 4.5 till 10 or 12.
10 nominal.
Nominal pressure.
12.
Yes, sir. Down.
Angio?
Angio, sir. So angiographically, we think we have done the good dilatation. Distally and proximally, it
In
looks
fact, we
okay.
have matched that remodeled segment.
Yeah, we look like we got the remodeled part, which was ectatic.
But actually our stent is proximal to that dilated part.
Yes, sir. But at that part, there was artery was hardly 4 mm, and the mid part was 4.5. So let's see what we have done. Otherwise, we might need more dilatation in the mid part.
I think we have to see first that remodeled segment. All the way from distal.
I think if it is less than 300 microns and if
Yeah.
it is less than upper mode, not more than 2 pieces, we can just accept that part. Ready? Okay. So it's well expanded. What we were having a distal under expansion, I think we'll take a one more proximal. So the distal part is okay, well expanded. Sir, एक proximal और ले लेंगे. We'll take one more run. Okay, looks good. So we'll just take out this catheter. So if you see now, it is well expanded, well opposed, not much. Can just rotate it, yeah. So expansion is good.
Stop it here.
Ankit, pakadna. So what is this? Can you just go distally? Can you tell me what is the stent expansion distally? So if you see the distal edge is fine, we're just starting from the stent strut actually. And the expansion which was
Little
earlier,
more distal.
actually we just, yeah, perfect. Start.
And go slowly.
So this look well expanded, no distal edge dissection, no significant malapposition, and good part is that there is no much tissue prolapse also. What we were expecting that we might get some, there is some prolapse near maybe around 7, 8 o'clock,
See,
but not very significant because we were expecting we'll have a thrombus, we'll have some prolapse there. And if we see the MSAs, every MSA is about 8 mm. So it's good 7.5 to 8 mm. So it's
go
well
proximally
expanded.
to the ectatic segment.
And once we are coming to the ectasia,
This is that segment.
There is some.
yeah. So
Yeah.
I think what is the distance? Malapposition कितना distance आ रहा है? Can you just tell me? So earlier it was like a circumferential malapposition, which was there. Now it is only in a
320
180-degree
micron.
arc. So I think
So it is.
300 microns we can accept that because if it is like
And
Atlas
we have
OCT
already
trial
done
showed it,
with
yeah,
4.5.
4.5.
So you
And if you
can't
see
do
the
it with the
arc also,
5.
arc has definitely decreased. Earlier it was 360-day arc of malapposition.
But it is
Now
still
hardly 180-degree arc of malapposition, and it is less than 300 microns, so we can accept that part. Because with ectatic, I think this challenge will always remain.
Yeah.
And what most of the studies have not shown that
but
malapposition is
still
a,
it is a concern for future follow-up as well.
yes, sir. But the only thing is like you might not don't want to go under the stent struts
Yes.
because otherwise malapposition has not shown any study which has shown that restenosis or stent thrombosis. And can you tell me what is the LED ostia size? Yeah, that's also pretty good. We are getting an LED ostia of 11 millimeter square, and ostia is clear. There is no studs hanging at the carina, and L6 ostia is well clear. So just ostial placement of LED stent, I think so. Is it right?
Yeah.
Just a little proximally. Can you have a 3D image? Yeah. Okay. Perfect. So we can clearly see that 3D image that there is no stent studs protruding in the L6 ostia. The L6
L6,
ostia is
yes.
totally roomy, and the distal edge, proximal edge also there is no dissection, no malapposition. So I think we did a pretty good job here. What do you think, sir?
Yes, the only thing is that maybe in the follow-up we may require to do angiogram down the line if some symptoms happens to be. Otherwise,
sir.
it's look pretty okay. The ostia is perfectly placed. The stent is perfectly placed. The ostia of the circumflex is okay, and I think it's a pretty good job.
Yeah,
Yes,
we achieved a
Virtues.
good expansion at the distal end also, and we just stopped at the ostia, LED ostia. There is no malapposition under expansion at the LED ostia. So there is a brief little length of that remodeled segment which is still malapposed by around 300 microns. But we'll accept that and we'll
Yeah, because
follow up it in
if you see the
future.
studies also, they are saying it should be at least 300 or 400 microns to cause to address this
Yeah.
malapposition.
Yeah.
So less than 300, I think we can
think
accept that part.
Yeah, because they're not
What do
very
you think, sir?
clinically
And
known to cause clinical events.
clinical events. So being a young patient, 33-year-old, we wanted to give a job which is having a long term. We can have a not much restenosis and thrombosis. So in that case, I think imaging really helped us in
yes.
diagnose, like seeing the plaque morphology, not going pre-dilatation with high pressure balloons, and especially post-stent expansion. I think in this case was very essential because we have remodeled segment, ectatic segment. We have to go ahead with it.
That's right.
Final angios.
So you can have a final angio, sir.
ले लो.
Do.
Good.
Okay.
Yeah, thank you everybody. Dr. Roopali, Dr. Ankit, the whole team, Dr. Kapoor. Thank you very much.
Thank you.
Thank you.